morning, everyone. Myself, Dr. Gaurav. I am from Hyderabad, Asian Spine Hospital. I will be discussing on full endoscopic radiofrequency ablation of facet joints for chronic back pain. So, chronic low back pain is one of the most common pathology in daily practice. Its prevalence is 3 to 10% in general population, which comes to our OP. Many structures involved in chronic back pain, such as ligaments, fascia, muscles, nerve root, dura, intervertebral disc, muscles, SI joints. So here we will discuss for the facet joints. Back pain, it increases due to degenerative process and inflammatory process. Elderly population has increased incidence. Pharmacotherapy is a challenge in such patients. Degenerative process affecting the lumbar facet joints are a frequent reason for chronic low back pain, which is usually underdiagnosed. So they are also called as zygapophyseal joints. They form by the superior and inferior articular process of the successive vertebra. Facet joints are true synovial joints for the which contains of hyaline cartilage, synovium, and joint capsule. Prominence of bone arises from the dorsal surface of transverse process near the junction of SAP, and this is called as accessory process. So we'll see into the next this thing. The innervation of the facet joint is basically formed by the medial bundle branch, what you call medial branch. So the dorsal root and ventral root at a particular spinal level combines to form a mixed spinal nerve. The mixed nerve quickly splits into the ventral and a dorsal primary ramus. So in lumbar spine, ventral root goes to the lower extremity, provides the motor control, while dorsal primary ramus loops posteriorly and splits into the lateral, intermediate, and medial branch. So it is the medial branch which supplies the sensation of the facet joints. So at caudal end of SAP, the medial branch enters into a fibroosseous canal. So from this fibroosseous canal, medial branch turns medially and caudally immediately to the caudal joint and is embedded into a fibrous tissue. Some kind of a hard tissue will be there surrounding the joint. So there is a concept of dual innervation. Exiting mixed spinal nerve gives off the medial branch, as we have seen just now, that supplies facet joint at the level and the joint below. So in this figure, we can see there is a facet joint which is coming from the descending branch of the upper one and the same level medial bundle branch block of the same level. So what are the indications? Chronic low back pain, facet joint hypertrophy, facet joint arthritis. Contraindications are current anticoagulations if a patient is on anticoagulant, negative perioperative infiltration testing, use of monopolar RF probe if patient has a pacemaker. So how we do the procedure? It is completely under local anesthesia. We target the junction of transverse process and the base of superior articular process. So we generally use an 18-gauge needle, 15 centimeter, which was inserted through sterilized skin and docked into the medial part of the transverse process, as you can see into the picture, over which guide wire is inserted and dilator is passed. So figure 1, there is a needle is inserted, and you can see in the AP projection the needle location. Eventual placement of the scope will be the second figure, you can see there. So once the needle is placed over which the scope is passed, this is the RF probe, radio frequency 4 megahertz probe we use in our practice. And this is a small video here. So here we are on the left side of the patient. So 9 o'clock is cranial, 3 o'clock is caudal, 12 o'clock is medial, and 6 o'clock is lateral. So you can see here, this is the medial bundle branch block, which is hooking over the transverse process. This is a transverse process. With the probe, we are seeing this. Then this is the superior articular process. This is a blood vessel here. Then we are hooking the medial bundle branch block, with medial bundle branch. I'll just a little bit fast forward. Then we introduce the RF probe. We coagulate it under vision. And we make a lesion there in the medial bundle branch. You can see the lesion is being nicely made. Then with the annular cutter, we try to cut the medial branch. So we do this at the same level and the level above from where the pain we think it is coming. So the nerve is completely now being lesioned, and again we achieve hemostasis around the nerve, and we have separated the nerve here. So next is we have labeled it, the same transverse process, medial branch, the superior articulating facet and the artery above it. So this is how we ablate in our regular practice, and but as we know, RF is safe, but sometimes it suggests that tests are temporary, lasting for less than 12 months. The reason for short lasting efficacy is regeneration of dorsal ramus, incorrect positioning of the needle. So here advantage of endoscopy comes. It is visualized, accurate position of the probe can be achieved, can target multiple medial branch sites. So if you cannot identify the cranial end of the transverse process, we can go and achieve at the lower end of the transverse process. We can trace the medial bundle branch. And of course, the important one is the hemostasis. So these are the literature which shows when you use endoscopy for visualize RF ablation, it gives a better outcome for the patient. Thank you.